Today's presentation will be on expanding roles in paramedicine and how they may be the answer to such issues as emergency department overcrowding and decreased ambulance capacity. This is an overview of today's presentation. We will start by talking about the expanding roles in paramedicine. Following this, we will address some immediate problems affecting the modern healthcare system. I'll discuss the role of community paramedics as a possible solution to these problems. And we'll also look at the current literature and see whether it supports or opposes the necessity of community paramedics. We'll also look at what community paramedics exist currently, nationally and abroad. And finally, we'll briefly look at what the future potentially holds regarding expanded roles in paramedicine. So to begin with, expanded paramedics. Ironically, healthcare demands are increasing as advancements in medicine lead to an increased ageing population. This ageing population provides new, complex, low acuity healthcare needs that the traditional paramedic who was trained in pre-hospital emergency care may not be able to effectively treat. As Atul Gawande, author of the Checklist Manifesto, notes, medicine has advanced rapidly, and as a result, interventions and assessments have become ever more complex. The medicine fraternity has responded by creating specializations within certain departments so that patient care standard does not suffer due to clinicians' lack of experience or knowledge in said field. The question then must be asked, why has paramedicine not followed suit? The current model of pre-hospital care and transport clearly isn't really working, with staggering statistics such as 50% of all patients transported to EDs are discharged from hospital with no major treatment or referral. With recent paramedic registration as well, Australian attitudes of some paramedics have shifted from one of "I'm happy to leave this patient at home, given what I've assessed and inquired about. The patient does not require emergency care, and I'll refer them to a GP or medical clinic for follow-up," to a perception of "I'm not prepared to risk my registration. I will transport to hospital regardless." The result is further overcrowding of hospital EDs and decrease in ambulance availability due to ramping. Current paramedic scope rarely include the necessary assessment tools and knowledge of chronic low acuity disease states to confidently and appropriately treat and refer. Additionally, healthcare availability and accessibility in rural and remote areas continues to be an unsolved issue. This is a global problem, with services from the United Kingdom, Canada, the United States, and America and Australia, just to name a few, are trialling strategies whereby a number of paramedics are trained with expanded scope of practice, able to treat minor medical conditions not requiring emergency department intervention, or those who can be referred or transported to non-ED facilities. The result of this being a decrease in EMS workload, providing the community with an increased system capacity and a decrease in response times for actual emergencies. Decreased ED overcrowding due to appropriate referral of low acuity cases as well, and finally increased quality of healthcare services to the patient. Overcrowding of emergency departments is a crisis. A retrospective study by Crilly J. et al. In 2014 investigated the feasibility of expanding ED bed capacity by a third. It began with around 81 beds and expanded up to 122 beds within Queensland, I think across 3 facilities. Outcomes measured included in-hospital mortality and time-orientated outcomes of ambulance offload time to see doctor, and ED length of stay. The study included a total of 286,037 patients over 3 years. Nearly 30% of these patients arrived via ambulance. Number of patients arriving via ambulance increased by over 2,000 each year as well. The only outcome which resulted in an improved outcome was in hospital mortality, which increased by 1.5%. However, time-related outcomes were poor, with possibly the most perplexing result being an increased offload time from stretcher of ambulance by 4%, even with a third more beds. The study concluded that the whole healthcare system needed to be reviewed, and the overcrowding issue had directly affected ambulance capacity and capability out in the community. Decreased ambulance capacity can be attributed to a number of factors, one of which is ramping. The inability of an ambulance crew to offload a patient at a tertiary facility and regain availability in a timely manner. This could be due to high acuity and emergent presentations via ambulance to ED. This is reflected in the study's analysis of predictors, including admission triage. The triage system used was the Australasian Triage Scale, ATS, as seen on the slide. With a great number requiring urgent medical assessment and treatment categorised between 1 and 3, with a maximum waiting time of 30 minutes. Regardless of this, triaging patients who arrived via ambulance were more likely to remain in ED for greater than 4 hours. It is not unreasonable to assume that a small amount of preventative action in the face of exacerbations of chronic conditions could limit, even dramatically reduce, the number of high acuity cases admitted to hospital via ambulance. This preventative action can come in the form of community paramedic. I believe at this point in time, we as a community are severely lacking in preventative action in public health, especially those who live remote or rurally. I like to use the analogy of the public currently swimming at an unpatrolled beach. Sure, we have paramedics who can respond when someone eventually drowns and gets washed ashore with the hope of reviving them, and the ocean being health, RIPS being the low acuity of non-emergent health concerns. But the majority of people, including paramedics, are unable to recognise these signs of imminent health threats until it's too late, by which time they call an ambulance. A professional with not only the emergency skills, but also the ability to recognise the low acuity health concerns, or RIPS, is needed. Community paramedics are the lifeguards of the community, educating the public and preventing the admission to hospital ED through preventative action rather than rescue. What is a community paramedic then? There are a number of nouns used to describe a paramedic with an expanded scope of practice. They include extended skills paramedic, emergency care practitioner, paramedic practitioner, and community paramedic. I must also make the preface that extended care paramedics, such as those that work in New South Wales Ambulance or the RURAs found in QIS, although similar, slight differences do still remain between them and a community paramedic. For example, a community paramedic, rather than reactive to a request for ambulance assistance, are more closely affiliated with the public health approach, which intervening occurs both prior to and or after the standard paramedic call with a focus on prevention. Both roles require an extended scope of practice and well-developed clinical reasoning decision-making. For the rest of the presentation, I'll refer to paramedics with an expanded scope of practice as a community paramedic or a CP. I do believe that terminology is important, and community paramedic to me encapsulates the vital role CPs play in the community, especially in smaller communities such as those found rurally and remote. The role of a CP, as I mentioned, not only includes the normal emergency assessment and treatment of patients, but also, depending upon which jurisdiction the CP is working within, will include such things as the comprehensive medical history and assessment and the initiation of treatment. Appropriate referral to suitable facilities, but if possible, the appropriate management of the patient will be carried out within their own environment, negating the requirement to transport to hospital. The CP can also order appropriate tests and is able to interpret these results and, based on the findings, initiate a short to medium term healthcare plan for the patient, importantly aiding and facilitating their recovery. The result is an ongoing relationship between the short, high acuity episode that paramedics are familiar with. Moreover, rural and remote communities with higher than average paramedic downtime, absence of other healthcare professionals, and extended travel times to appropriate healthcare facilities could greatly benefit from the addition of a community paramedic. The broad scope and flexibility of such a role could meet the healthcare needs of these communities. To put it blunt, this seems like the ideal solution for both rural and remote communities. The public healthcare system regarding cost effectiveness and possibly reduction strain on the current model can all benefit. So, does it work? Due to the global infancy of community paramedicine, current literature is sparse. One systematic review included and assessed the quality of 8 retrospective observational studies, and that is Greg A. et al. 2019, who implemented the grade system to assess the quality and found that 4 of these studies were considered of low quality and the other 4 moderate quality. These variances occurred due to sample size, reliability, and validity of measurements and of outcomes, and the study's attempts at excluding bias. The review included 4 measured outcomes. 1 was reductions in healthcare cost, 2 improved healthcare outcomes, 3 improved patient experience, and 4 improved provider experience. All studies measured at least one of these outcomes, and that outcome was reduction in healthcare costs. And 3 studies investigated the outcome 2 regarding improved health outcomes, of which all found positive improvement of health outcomes. Patient satisfaction was assessed by 4 studies, all of which found increased patient satisfaction. One study, however, found no increased satisfaction when compared with traditional paramedic care, but overall high satisfaction. However, due to all studies included in the review having taken place within the United States, the applicability of these results are uncertain. Furthermore, the size of scope and level of training varied greatly and possibly affected the outcomes as well. Examples of community paramedics today. So within Australia, New South Wales Ambulance have the ECP, or the Extended Care Paramedic, not quite a CP, but actively moving towards a practitioner model with tertiary education. Ambulance Victoria have the Paramedic Community Support Coordinator, same clinical skills as an ECP. Again, Ambulance Victoria exploring the expanded scope idea based on community needs. QAS have the Isolated Practice Area Paramedic, more closely aligned to the traditional CP scope regarding public health awareness, i.e. Australia-specific Aboriginal health and health promotion practice and chronic complex disease understanding. South Australian Ambulance, an informal model of rural hospital support paramedic, which includes skills such as suturing, plasters, and all of these within a hospital setting. The Tasmanian Ambulance Service has the East Coast Paramedic, which assists hospital staff in triage and initial treatment and intervention and treatment, blurring the lines between pre-hospital and in-hospital care. Western Australia St John's has the community paramedic, so that role entails assisting local medical centres and facilities with treatment and care of patients, and provide healthcare cover where there is a lack of doctors and nurses. Northern Territory St John's has no official title at this stage, however, it is an adjunct to nursing staff in hospitals. What does the future look like? Well, application of community paramedics will gain more momentum as more are introduced into healthcare services globally. They will challenge the current model of pre-hospital care provided by the traditional ethos of paramedics that non-emergency patients are another health professional's problem. Challenging this model will eventuate a shift from the perceived core role of emergency response to a more patient-centered approach, further bolstering the community's health awareness and contributing to a healthier community. I would like to take it back to the analogy I used earlier. I hope that paramedics and community paramedics will fulfill their duties as health professionals, preventing patients' health to decline to such